Hello, everybody. Welcome. My name's Dr. Susan Varano. I am double board certified in internal medicine and geriatric medicine, and I have quite a bit of experience with various types of settings, assisted living, long-term care settings, outpatient settings for my older adults. And I was asked today to give a lecture or a discussion, we can make it however you want, I'm pretty flexible, on COVID-19. And I think that the flyer that you all have, and I always like to review that first so that we have our expectations together, is just to join in a discussion, and it is a discussion. So if you have a question and you want to ask it, feel free. Or if you want to wait till the end, feel free. And I will certainly stay afterwards if you have a question and you don't really want everyone else to hear it. You could certainly talk to me afterwards. So it's join a discussion on the research, the science, the fears, rumors, and protocols of our pandemic at COVID-19. So I wanted to start off with talking about the clinical trial, and then we'll jump into the virus and how this particular virus, why is it causing so much problems in the world, essentially? How does it differentiate from other viruses? And then we can proceed talking about prevention with vaccines, a whole variety of different ways we can talk about that, including news that just came out today. And then if we have time, we can jump into treatment and potential treatment for this vaccine moving forward. Okay, so let's start off with the Pfizer trial, and I'm going to focus predominantly on the Pfizer trial, although Moderna has similar mechanism of action and efficacy and safety data. The reason why I want to predominantly work on the Pfizer trial is because I was chosen in April to be one of 150 clinicians worldwide, globally, in 6 countries, to run the COVID-19 vaccine trial. And so as with all trials, I review the protocol and see whether I feel it's a good fit for my clinical site. And it was a fast enrolling trial. There's a large number of patients that we were expected to enroll. And we took a lot of effort, and we took it to heart. We actually doubled the size of our staff, doubled the size of our physical office. I hired quite a number of sub-investigators to assist me in making this trial as successful as possible. And we accepted it, and we, alongside with the other 149 clinical trials, enrolled over 44,392 patients. So 44,392 patients, 6 countries, was a very respectable representation of patient populations. And so I say that because there's transparency is critical, and for those who are not trial believers, it's important to understand the science and the data so that you can make an educated decision as to whether this is the right avenue for you or not. And that's my goal today, is to present the science, present the data. If anyone doesn't agree with it, feel free to speak up. If, once again, you want to talk to me afterwards, feel free to do that. This time is for you. It's not for me. It's for you to hear some inside information from me as the principal investigator, and for me dealing with this as a physician on a day-to-day basis, and share with you my experiences, both positive and negative, when it comes to this disease state as well as the trial. Okay, so of all, I've done many vaccine trials. A couple of trials that I'm ongoing right now is I'm working on a Lyme vaccine trial because we don't have a vaccine for Lyme, which is also a very devastating illness, as well as a host of other trials. And I've done hundreds of trials, a lot of them having to do with flu and so on and so forth. So I'm very comfortable with the vaccine world. And for the most part, all vaccine trials have the same goal. And the goal is to train your immune system to recognize and defend against organisms. Conventional vaccines, the ones that I'm most comfortable with, may use a weakened, dead, or non-infectious particle of that vaccine or bacteria, and that is put into your body. This vaccine, however, the Pfizer COVID-19 vaccine and the Moderna are different. And what's very exciting about it is, although this ability of messenger RNA has been around for a very long time, we actually brought the science into practice. And I think that's what's making a lot of researchers so excited and energized about this vaccine platform, because not only is it currently successful for COVID-19, but we're thinking that we can extrapolate this data and make it successful for a whole host of other disease states that are devastating. So this is very exciting time in science. And I think it's very exciting time for patients, because they can have a change of different disease states that were killers in the past. So how is it different? And this is the only part of the presentation that's a little bit technical, but it's important to understand. So this particular vaccine, messenger RNA vaccine, is different because we introduce the gene that codes for the protein into our cells. Then our bodies make the spike protein. Everyone knows of the coronavirus as that image that you see in your mind with the circle with the spikes coming out. And that's what our body is designed to do once they see that gene. So we introduce the gene that codes for the protein into our cells. Then our bodies make that spike protein that we see in the cartoons. Then we make antibodies to that spike protein. Okay. Once we have that, it's important to know that messenger RNA does not stay in your body, and it cannot make any other changes. I get questions all the time: are we manipulating our genome? Are we going to make superhumans? And the answer is absolutely not. It's been studied and it's unanimously known globally. And to have anything unanimously globally pretty much makes it very safe to say that the messenger RNA does not stay in your body, and it cannot make any other changes. RNA is a chemical that lives a very short time in your body. And once the messenger RNA is read and transcribed into a protein, that spike protein that we see in the cartoons, it is quickly discarded. There's a system in place in the cells and the body that immediately gets rid of the RNA after it's been read. So basically, it's similar to reading a page in a book, and then you rip that page out and you throw it away. You're done with it. So when we were doing this study, we expected that we would have 60% efficacy, because in all our, not all, but in many of our flu vaccines and once again, other clinical trials, 60% efficacy, we were very happy. But what's fascinating is that we received 56% protection after the first dose, which was week 3. Then we had the patients come back, and once again, this is Pfizer. 21 days later. Moderna is 28 days later. And we had patients come back 21 days later, week 3, and we did a nasal swab, we drew their blood, and we gave them the second vaccine. And we've identified that 95% efficacious results as a result of the second dose. That's pretty spectacular, I have to say. We're hoping for 60, and we got 95. And then when Moderna came out with their results being 94% efficacious, it pretty much showed some consistency in the messenger RNA's ability to work on this virus. So when getting data like this from profitable institutions such as Pfizer and Moderna, of course, there's going to be questions related to it. But having been the principal investigator and having worked in clinical trials since 2005, and I've been working in clinical trials simultaneously as I worked at Yale for 20 years as an inpatient geriatrician, creating 2 programs, both the hospital elder life program and the geriatric consult service. Clinical research has always been a fascination to me because I wanted to see how the science actually translate into my patients getting better. And I have to say, over all my years of clinical trials, this trial was probably more regulated than any other simply because it was so highly publicized. So not my site, but other sites were getting FDA audits to ensure quality before any of the results that you've read in the news were released. My staff, we had double staff to make sure our I's were dotted, our T's were crossed, because we just didn't want to make a mistake. We couldn't afford to make a mistake. We have an observer whose job is strictly to observe the nurse taking out the medication, mixing it, and administering it to the patient to ensure that everything is done as outlined in the protocol. So I'd have to say very confidently that what we read in the media as far as the efficacy and safety is absolutely what I have witnessed as the principal investigator in my clinical site, which is only one of 150. However, with that being said, because I'm the physician of record, any adverse event, any severe adverse event, any poor outcomes comes on my desk. And I have to sign off on it to say, I am aware that this has happened in another country or another clinical site, so that if it does happen in my site, I know how to handle it. And I have to say the number of adverse events were minimal. And the side effects were predominantly after the second shot, and they were pretty much local reactions, swelling, pain. Some individuals had some lymph nodes that were a little bit more enlarged, some fever, some symptoms that are saying that your immune system has seen a foreign spike protein and is reacting to it. So some of my patients were thrilled when they had these reactions because they knew they got drug and not placebo. So those were pretty much the side effects that we had seen, quite minimal in exchange for protection of not getting COVID. So the vaccine trial did not study for transmissibility, which simply means that it studied for you so if you received the vaccine, you're 95% efficacious. 5%, however, means that you are still able to get COVID. And you can transmit it. So the goal of the vaccine is to prevent your hospitalizations, to prevent those severe reactions, even if you are home. Okay. However, if you're asymptomatic, we don't know that you have the disease, and so you could transmit it to others. And so what the recommendation is to, despite the fact that you have vaccinated, to continue to wear your mask and to continue to social distance and to continue to wash your hands until we reach this level of what's called herd immunity. And herd immunity is at least 60–70% of the population being immunized, which means then if I'm immunized and I only have a 5% chance, and you're immunized and you only have a 5% chance, and we could have everyone else in that same category, the chances of sharing the virus, asymptomatic or otherwise, is quite minimal. Okay? So that's kind of the ultimate goal. A little bit about the virus, because some people are not, if you don't see somebody with COVID, you don't really respect it. And having worked in assisted living for quite some time, and during this pandemic, I did see some patients in my assisted livings, and it was very disturbing to go into work and to see, I go to the room and to see that the panel does not have the patient's name on it. And I'd say, where's Mrs. Jones? Mrs. Jones passed. So it was very real for me, not only in the assisted living for my seniors, but for my young staff. Nurses who are very, very young, early 20s, aides, early 20s, would have this devastating virus and the consequences that went with it. So it's an equal opportunity invader. And we're trying to study now, why is it that young, healthy marathon runner is in the ICU next to the 85-year-old who has diabetes, hypertension, and multiple comorbidities. As a geriatrician, I respect that the aging process creates multiple barriers to fighting infection. But it's very curious to me how I could have my older adult, which I expect not to do well with this virus, next to the bed of someone who's an ideal healthy individual. And what we're learning is that there's genetic predispositions to who's vulnerable and who's not. And you see quite the contrary. You see the 95-year-old who survived, or the 106-year-old who survived. Why is it they survived and the 20-year-old passed? It doesn't make sense, but it does when there's that genetic variable to it. And what we're thinking is interferon is one dysregulation that we're working on and possibly doing clinical trials to see if we can address those young individuals with this genetic predisposition. So let's talk about the actual virus and how it differentiates from the flu. It's not just a respiratory virus, it's a systemic virus. And it's very, very different than the flu, because if you have the flu, I've never had the flu, but my patients explained to me, it is essentially as if you've been hit by a truck. And it doesn't matter if you're 10 years old or if you're 110 years old. You feel completely wiped out, non-functional, and it's the worst feeling ever. However, once you've recovered from the flu, it's a bad memory. It's gone, it's over. There's no residual effects. COVID-19 is fascinating in the sense that there's quite a bit of long-term damage that we're seeing with our long hauler syndrome, and our clinics we're identifying. And since it's only been around for a relatively short period of time in comparison to other disease states, we really don't know what's going to happen to this individual 5, 10, 15, or 50 years from now, because obviously we haven't been there yet. But the key points is it is not a localized respiratory infection. It's a systemic infection. And the different systems that it attacks is, one, it creates increased allergies. 2, it affects the sense of smell and taste. And what's fascinating about that, it's not that the nerve is damaged, but it's the supporting system surrounding the nerve. It's the blood supply. It's the myelin to the nerve. And smell retraining is very helpful. So a lot of individuals who've lost their sense of smell and taste should actually go for, believe it or not, rehab. And we have to retrain the brain that this smell is roses or fire or salt or whatever we're trying to retrain the brain to identify the smell. Helps quite a bit. But I've known many adults, young adults, who lost their sense of smell in March and don't have it. Don't have it back. It has not returned. Okay. Hearing loss. We don't really read on the media how COVID can create a hearing loss, but it's true and it's existent. And what we're seeing in our long haulers post-COVID clinics is that individuals who have recovered from COVID have an increased incidence of heart attacks 2 months post-COVID. So not only were you insulted with COVID, but 2 months later, you have a heart attack. Now, does this happen to everybody? Absolutely not. And that's what's really, really curious, fascinating, and concerning. All those words would describe how I feel about this illness because there's so much unknown. So heart attacks are definitely something we monitor for. And for the older adult, cognitive impairment, in which we're now defining as dementia. And I see quite a bit of my older adults who are completely independent, living at an assisted living, cooking for themselves and cleaning and just completely independent, come home from the hospital with COVID and their mind is as if it's a pseudo dementia, but now it's lasting way more and there's nothing reversible. And so now we're starting to call it dementia, which is very disturbing to me because that's something, one of my passions is identifying, treating, preventing, and so on, the different types of dementia, specifically Alzheimer's. So this is very offensive to me that this virus is contributing to cognitive deficits in which we're now labeling it dementia. COVID-19 is also very similar to other autoimmune disorders that we know, such as lupus and rheumatoid arthritis. So once you get the COVID infection, basically the body revs up the immune system and it shuts down the virus after 7 to 10 days. But the immune system doesn't stop. So it goes into this second phase of immune dysregulation, and it almost acts like Lyme disease, in which you have a waxing, waning, fluctuating feeling. One day you feel great, one day you feel horrible. And if you know anybody who has had a serious episode of Lyme disease, they will tell you years later, they still have that waxing, waning feeling. So we're starting to gather data to say, what exactly can we do and what exactly is going on? And in our post-COVID clinics, we're noticing that a lot of individuals are complaining of GI symptoms, diarrhea, nausea, loss of appetite, the long hauler syndrome, which is the brain fog where our young doctors, our young nurses, and our young students are not clear. They can't think clearly. It's as if they haven't slept in a while, and their brain is clearly not the way it used to be, and they describe it as a brain fog. Loss of processing ability. So you ask them a question and they look at you for a couple seconds, even as long as a minute, to try to get that answer. So loss of processing ability. Now, for someone who's your physician, or for someone who's your accountant or your lawyer or your dentist, that's not something you want to see. When you're in the dental chair and you ask them a question and the dentist is staring at you trying to process it, you want to get off that chair and run away. So it's affecting the person who has the COVID because they're losing revenue, because their clients, their patients, their boss are seeing these deficits and don't want the liability associated with it. So it's quite devastating. Our long haulers are also complaining of chronic shortness of breath. Some of them are on continuous O2, chronic fatigue, headaches, but not just a little tension headache, a debilitating headache, almost consistent with migraine quality type of headaches. Chest pain different than heart attack chest pain. It's more of a nuisance, a discomfort. Cardiac chest pain classically is pressure, and we teach the medical students to say it's an elephant sitting on my chest. But this is more of this chronic nuisancey discomfort that you can't figure out what it is. And then surprisingly, which a lot of people don't talk about, joint discomfort. Taking all these symptoms that you didn't expect to have, it's not uncommon that we're seeing post-COVID patients with anxiety, depression, feeling of hopelessness. Our statistics have shown that if you're greater than the age of 70 and you get COVID, the chances of passing, the chances of dying is 13%. So it's extremely, extremely high, just because of age alone. Then if you add on genetic predisposition, comorbidities, those numbers certainly go up. So before I go on to talking about a little bit more about the vaccine and some treatment and whatnot, I just want to kind of review some key points where we're at right now. That with the vaccine, the messenger RNA is temporary. It's not permanent. So if any of your children or grandchildren are concerned about that, you can have them turn to the science and see that it is indeed temporary. COVID is not a respiratory illness exclusively. It has multiple organ system failures that the duration is unknown. It could be weeks, it could be months. I mean, we do have many patients who have COVID who have recovered completely. But then, of course, we have those who have not. So the risk of vaccination versus the risk of illness, in my opinion, it's a sound strategy to get that vaccine rather than to take your chances with COVID. So that would be my recommendation. But there's quite a bit in the media of people being concerned on whether it's the right thing for them. And I thought this was a great opportunity to kind of highlight what the concerns are and give you the science and answers to those questions or concerns. And then, of course, we can open it up for discussion at any point. First thing I want to say is if you have a question about the virus, about the drugs, the best place to go is where we, the physicians, go, which is the source. So for the virus, for example, if you go under, if you're comfortable using the computer, and if you're not comfortable using the computer and you're in one of our assisted livings, of course, the staff will help you and work with you. And maybe there could even be a little workshop where everyone can look at it together. I think it's extremely valuable. And I spend the time with my patients going on the website because it's a tool that I want them to use as often as they need. So it's capital C, capital D, capital C. So cdc.gov, and you do /coronavirus. And it has different tabs for healthcare providers, for consumers, and you just click on whatever topic is of concern to you. So for example, my children's superintendent sent out an email that the CDC is recommending double masks. And she is considering, although has not mandated it, but is considering having our children double mask to school. And I have to obviously be careful on my opinions and whatnot. So what I had forwarded to her was a snapshot of the CDC's recommendation on the double mask. And what's interesting is the superintendent simply said, I'm thinking of double mask, but she didn't go into the details. And so when you interview students or faculty and say, when you read that, what is your take home? And they'll say, well, I typically use a disposable mask, so I use 2 disposable masks. Doesn't that make sense? And the answer is, it does make sense as the superintendent wrote it. However, if you look at the science and you look at the CDC website, they are recommending double masking, but they're not recommending 2 disposables because the disposable is not designed to be tight fitting. So I would encourage you to go onto their website, and when you read or you hear something on the news, you want to get the full story. And what I really like about the CDC is I went on there and I shared it with the various schools and whatnot. They have a video, a YouTube video on how to make a disposable surgical paper mask much more efficient in reducing the particles going into your system and reducing your respiratory particles going out. And it teaches you how to, basically you take the mask and you tie each of the bands as close to the mask as possible. And then they show you how to tuck in the sides so that it's extremely well fitted. Once again, going on to the cdc.gov/coronavirus website, it's very clearly marked. You just press the YouTube button and you have a physician teaching you how to make that paper mask much more fitted and efficient in reducing contracting this disease. The next site I would recommend is if you're curious about the vaccines. Well, the best place to get the answer is the company. So if you go under Pfizer.com, and it's Pfizer.com, they have all transparency onto the clinical trials, the patient population, the side effects, everything you could possibly want to know, they have. And they have to share with you what their findings are. Now, if you, as I did today, for example, heard the news. So today, I heard the news that, let me just pull it up. So I got a little news clippet that says Pfizer and biotech submit COVID-19 vaccine stability data to at standard freeze temperatures to the FDA. So to me, that's really fascinating because we were waiting for Johnson & Johnson and other manufacturers to come out with a vaccine that doesn't need this deep freeze. And now Pfizer, supposedly, according to the news, is doing this. So what did I do? I went onto their website to see what is the press release, what is the news release. I don't want to hear it secondhand from a newscaster, a 30-second, snippet of what Pfizer said. I want to see what Pfizer said myself. And I encourage each and every one of you to do the same. So all I did was I went under Pfizer.com/news and I read the press release. And basically what it says is that they submitted to the FDA that the vaccine can now be stored at -25 to -15, which is pharmaceutical freezers. So what does that mean for you? That means for you that it's going to be readily available pretty much at any pharmacy. Here in Connecticut, we do have pharmacies that already have them, but they have to purchase these freezers and there's only so much room in the pharmacy. So they have a finite number of vials. But with this extension of changing the temperature regulation, there's going to be vaccine available all over in all countries that don't have these deep freeze freezers that I have. So I encourage you to, once again, go on their website and see what they have to say. The other very important part is the question of, whether this vaccine is safe, whether it's not safe. So what I wanted to do before I, over the next minute or so, is because I do think it's very important for you to be empowered and for you to know the real data, is I went on the Pfizer website and wanted to share with you pretty much what they say is safety prescribing information. So if you have any concerns, whether it's right for you or it isn't right for you, this is what they clearly have. They clearly say that the immunocompromised person, including individuals receiving immunosuppressant therapy, may have a diminished immune response to the vaccine. That doesn't say that they can't have it. It just says they might have a diminished response. So any response, in my opinion, is better than no response. It also says that the adverse reactions are, So I'm going to just pause for a second. So there was a question in the chat box said, do I suggest having the vaccine administered if you're pregnant? And thank you for asking that. I was invited to be part of the Pfizer's clinical trial for pregnancy. And since I don't do OBGYN and I don't do children, those were the two other clinical trials they asked me to participate in, and I turned them down. However, with that being said, if you are in childbearing age, hold on, let me read this. What is, okay, I will answer that in 1 second. But let me just answer the one on the pregnancy, and then I'll answer the one on diminished response. Forget answering your questions. So if you are in childbearing age, I do recommend getting the vaccine because you want to have as much immunity as possible. If you are pregnant, the trials are ongoing right now and we don't have the data. Once again, I'm not in that trial. I'm not the principal investigator, so I can't even give you kind of insider information as to what I'm seeing because I'm not doing it. But I would say if you're actively pregnant right now, I don't have any data for or against it. So that would kind of be your own decision to make. I can't really give that. I can't give that response based on no science that goes with it. And for someone had put in the chat box, what does diminished response mean? So diminished response means less of a response. So if you're immunocompetent, means that your immune system is as full force as possible, and anything that comes your way, you can attack it. As you get older, your ability to fight infection is diminished. If you're receiving chemotherapy drugs, or if you're receiving steroids, they knock your immunity down also. So you have diminished response, meaning that your body will recognize this spike protein, but it doesn't have enough fighter cells to get the response that someone who had 100% immunity could. So diminished response means less of a response. And that's why if you are going to get the vaccine, it's advisable not to take Advil, ibuprofen, Tylenol prior to the injection, because you will suppress the response. You will diminish that body's ability to fight the proteins that we just gave it. So don't pre-medicate for your vaccine. Post-vaccine, I prefer you not take any antipyretics, Tylenol or ibuprofen or whatnot. Someone's just writing, what about hydrocodone? So painkiller. So I would prefer either before or after not to. If you have to, you have to. But if you can go into the vaccine with no suppressants, no cortisone, no steroids, no painkillers, no antihistamines, if you could just go in, get the vaccine, have your body is in its native state as much as humanly possible, it will make the greatest response. And you'll have B cells and T cells and everything will be ready to go so that if you do get exposed to COVID, it will fight it. After your vaccination, the recommendation is to ideally wait 12 hours at the earliest, because you don't want to suppress your body. You know, if your body is having fevers or chills or body aches or pains, it's your body saying, I see something foreign, I am going to kill it. So your body is revving up so that when you actually get exposed to the true virus, not the vaccine, but the true virus, you have an army prepared. Now, with that being said, if you are absolutely miserable and you can't handle it, then go ahead. You know, you have to do what you have to do. but that would be my recommendation. So going back to the Pfizer website, which I highly, highly recommend, they give the prescribing information and it answers all the questions you can possibly have. So question is adverse events. The biggest adverse events that I saw in the clinical trials were injection site pain, fatigue, headache, muscle pains, chills, joint pain, fever, and swelling, little redness, maybe some nausea, weakness, and some swollen glands. It doesn't last that long. Some people it lasts a day, some people it lasts 3 days. It certainly doesn't last weeks and weeks. And once it's done and it's over. Usually it's the second injection. It's not usually the first. However, with that being said, if you have any of these reactions on your first injection, and these are the minimal adverse reactions that we just talked about, you can go ahead and have the second injection. The only time we say you cannot have the second injection is if you have an immediate reaction, an anaphylactic reaction, which typically happens in 4 hours. It doesn't happen a day later, or because a lot of people have the vaccine and they're fine, and then the following morning they wake up and their arm is painful. A couple little tricks that I tell all my patients: exercise that arm as much as you can. You can put compresses on it. The CDC even recommends putting some wet cloths on it. They have a whole bunch of different tips for you to decrease those swellings. And for myself, I did that and I didn't really have too much pain at all. The other, I just want to pull up another sheet here, hold on. Side effects that are important is for the person who chatted me about pregnancy. I want to read to you what they have so that you feel comfortable. So it says, available data on the Pfizer vaccine administered to pregnant women are insufficient to inform vaccine-associated risk in pregnancy. So because the clinical trial is ongoing, we simply don't know. So that would be a decision that you would have to make on your own. Now, those who've had a baby, if you're going to ask me about breastfeeding and or pumping milk for the child, once again, right below the statement I just read was another statement saying data is not available to assess the effects of the vaccine on breastfed infant or milk production / excretion. So once again, those two are unknown. I'm expecting that we'll have that data relatively soon, but right now we don't. Let's see what else. Okay, the other question that I get a lot is I had the Pfizer vaccine for my first shot. Pfizer is 21 days for the second shot and Moderna is 28 days. So I had the Pfizer vaccine for my first shot, but it's not really convenient. Can I get the Moderna shot for the second one? Because after all, Dr. Varano, you're telling me they're similar in efficacy and safety and both the messenger RNA, so what's the big deal? And the big deal is we haven't studied it. So we simply don't know. So there's no data available on interchanging Pfizer with Moderna, and it's just not recommended. So if you get the first Pfizer vaccine, stick with the second Pfizer vaccine. So now the next question I get is, well, the first, you're saying, the first vaccine is day 1 and then 21 days, I have to do the second Pfizer vaccine. Well, I can't do it on day 21. I would say you can certainly do it anytime after day 21. You don't want to do it before the 3-week period, but we don't have right now an upper limit of when you can extend that. So the minimum is 21 days, but you could do it 28 days, you could do it, 30 days. We don't have a finite time. I would suggest doing it as close to the 21 days as possible, but you don't have to panic if you're, 22 or 28, because we don't think that that's going to be a problem, but you do have to have it, the second vaccine, in order to get the full 95% efficacy, because a lot of people are saying, well, one is good enough. And one will give you partial protection, but two will give you the greatest protection that we have in existence. Okay. All right. So those are the big points that I wanted to share with you. I want to open it up for discussions, questions, because we have about 10 minutes left. Let's see. Oh, I missed that chat. Hold on. Someone just came up with a chat. Okay. So I just want to make sure that I got all the questions here. Do you think the senior living operators should mandate vaccines for workers? So that's a tricky question. And I would have to say that in light of the fact that with my clinical trial, we had over 44,000 patients. Now, this vaccine has been worldwide. I mean, I have physician friends in Mexico who are giving the Pfizer vaccine. All over the country, they're receiving it. And the number of adverse reactions are minimal. Now, you're going to hear in the news about this one having this problem, this one having that problem. But the science is critical. The science is critical because if we look at who had an anaphylactic reaction, did they have a predisposition? Did they have a predisposition to anaphylaxis? Yes. If we look at any of the side effects, I mean, people are people. And so if I'm destined, let's just say, because my blood pressure is, 200 over 190, and I have other comorbidities and whatnot, and I'm destined to have a heart attack because I have 99% occlusion of my artery, and I get the Pfizer vaccine and I have my heart attack. The Pfizer vaccine did not cause the heart attack. I had a predisposing medical illness that the heart attack was inevitable. It's just a matter of when, and the timing was there. I also get questions of, well, could the vaccine give me the virus? And the answer is no. And in clinical trials, what I do, everyone who gets the vaccine gets swabbed. They get swabbed before I administer it. And the reason why is because you come in, you're perfectly fine. Now I give you the vaccine and you call me up in 2 days and tell me you're dying and that you have COVID and I gave you COVID. And that's not what happened. The reason why we swab is because on that day of vaccination, we can tell you whether you were COVID positive or negative. And once again, it's a large number of people. So it's possible that you walk into the center with COVID and not know it because you're asymptomatic at that point. I give you the vaccine and a couple days later, now you have symptoms and you test positive for COVID. It's because you've had it before you got the vaccine. So to answer the question of, do I think the senior operators should mandate it? I think that the vaccine is extraordinarily safe. I think that the benefit for the person receiving the vaccine is unbelievable. And then I think that preventing someone else getting it from you is a humanitarian effort that is critical for our survival. So mandate, I'm not in a position to say. I know that the government is talking about vaccines and their roles and what can and we cannot do. I would absolutely say that it would be ideal to have 100% vaccination in both residents and staff. And you guys are going to be well off. You're going to have a better quality of life. Because remember, this coronavirus is not the flu. You're not just getting it and getting over it. It's debilitating. And it's sure it could cause mortality, but the morbidity, the consequences as a result of it are devastating. And we don't know, once again, what's going to happen in 5 to 10 years. So I would love to see 100% immunity. And if there's anyone on this Zoom who's hesitant, who has vaccine hesitancy, please speak up, share your concerns, share your rationale, I suppose, for the vaccine hesitancy so that I can share with you the science. Ultimately, you make the decision, but I can share with you the science so that you have the tools necessary to make that educated decision. We have a few more minutes. Any other questions, either through chat or if anyone wants to talk, feel free. Mark, any comments?
Can you hear us?
I could hear you now.
Hello?
I could hear you now.
So one of my residents is wanting to know how long after they receive the second vaccine are they considered immune? Or what is their immunity rate, I guess, after the second vaccine?
Right. So after the second vaccine, so now that's an excellent question for many reasons. One, a lot of people feel that once they receive both vaccines, they're immune and life goes back to normal. So to answer your question directly, after the second vaccine, we say a couple weeks until you have that 95% level of immunity. But as far as I'm concerned, when I received the second dose of vaccine, and by the way, I received the Moderna because that was what was available, and so that's what I got, which is kind of weird because I did everything on Pfizer, but that's where my name was called on the list as the physicians, and I went where they told me to go, and that's what was available, so that's what I got. But for myself as the physician and for your residents, I would say it's nice to know that you have 95% immunity, whether that happens in 2 weeks, 3 weeks, or a month. I don't want it to be a false sense of security because you do have 5% that is not covered, and we have not reached herd immunity yet. So let's just say you're in a community where 100% of your staff is vaccinated and 100% of your residents are vaccinated, and the outside contractuals that come in, the PT, the OT, the entertainers and whatnot, and they're all 100% vaccinated. Well, I would be way, way, way more comfortable in you feeling that you have the superpowers, okay? But until you get to that point, I would be very, very concerned because a lot of individuals who do have both vaccines feel they're immune, and now they're not wearing their masks, and now they have the COVID fatigue. They're tired. They're tired of washing their hands. They're tired of all the restrictions, and now they feel, well, I'm safe. And that's where we get into a lot of problems. There's a question on my screen here that says, could one spread the COVID after you've been vaccinated? And the answer is yes. So because you have 5% that's not protected, you can be one of those 5%. Now, does that mean that you should say, well, then why bother? Why bother even, putting myself through 2 vaccines? And the rationale for me saying, yeah, you should definitely do it is because you're now 95% protected. You're 5% vulnerable, but you're 95% protected. But Think about it. If you do what I do, so what I do is I have both vaccines, and despite that, I say, okay, I have 5% and I don't want this. Trust me, I don't want this. It is so scary to me, and I'm going to be quite honest, that I actually purchased disability insurance and life insurance because I see my colleagues. I see physicians who I never expected to pass. I see physicians who were forced into retirement who weren't ready to. I see physicians who don't have disability insurance and now are losing everything because they can't work. So for me, I'm very, very scared of it. So what I say is okay. And I deal with it every day. I mean, I'm the one who's doing the swabs. I did yesterday, not yesterday, 2 days ago, I did 48 swabs, 48 swabs. And all those individuals I had to do a physical on. So I was really up and close on all of them. Anyway, so I'm at very high risk. So I say, okay, I have 2 vaccines, that's great, but now I have 5%. So what do? I put on my N95 mask, or you could put on your regular mask, or you could double mask. Then I wash my hands. Then I sanitize. So I do everything. I social distance. I do everything possible to say that 5% is not going to get me. And now, whether it gets me or not, I can't say 100%, but I do everything I can in my my power to take that 5% and make it a non-issue. So to answer the question, could one spread the COVID after you've been vaccinated? Yes, you can. And you can get it too. You can get it and you can spread it. And chances are you would spread it more because the COVID vaccine is designed to decrease your symptoms. So it's meant to take that ICU patient and make them moderate, the moderate patient and make them asymptomatic. It's to diminish the response that the virus is supposed to create havoc on your body. It's supposed to minimize what the virus can do to you by you fighting it. Any other questions from anybody? You guys have great questions, and I'm happy you're asking because I want you to feel comfortable.
When do you think we're going to get normalcy?
So the question is, when do I think we're going to get normalcy? And I think the answer to that, Mark, quite honestly, is once 60% get vaccinated. We do have variants out there, and I get questioned all the time. Okay, Dr. Varano, I'm vaccinated. Now what? Now there's these new variants. To let you know, the Pfizer vaccine definitely has been studied against these variants, and it's neutralized. So it's basically protective against those variants. And they're working, Pfizer and Moderna are working on boosters, on thinking ahead of if there's a variant that we're not protected against, well, we're going to take that messenger RNA, change the genome, and we're going to have people come back for another shot. But, those are booster shots. So that's why it's critical that everyone gets the 2 series so that if they need a booster, it's just a booster and they're not starting with the series from scratch. So I think once we get enough people vaccinated, then the transmissibility will be minimal, because remember, if I'm 95% protected, 95% chance I'm not going to give it to you, I'm not going to get it. And if your whole building is vaccinated, it's going to be really hard for that virus to survive. It just won't.
Can you hear me?
I can hear you.
Okay, this may be a silly question. I have 2 questions, and they both may be silly. I think you answered the first one. If a person has COVID, there's no use in then getting vaccinated at that time, is there?
Is this Donna?
Yes.
Hi, Donna. Thank you
Hi.
for asking. So Donna, that's an excellent, excellent question, and I'm sorry I didn't address it. I'm so happy you brought that up. That's not a stupid question. That's a phenomenal question. And the reason why it's so incredibly phenomenal is because a lot of people have that exact thought process, which makes sense, right? I had COVID, I'm done. Like I had chickenpox, I'm done. Unfortunately, that's not the case. So what is recommended that is if you've had COVID, we're expecting you to have antibody protection for 90 days. After that, we're thinking that the amount of antibodies in your body are not sufficient to fight it, and you could get reinfected. So anyone who's had COVID after 90 days, we're highly recommending that they get vaccinated, because the vaccine is going to give you the amount of protection necessary. Because Donna, your immune system may have been working at 50%, and Art's immune system may have been working at 75%, which means you're more vulnerable. So we don't know what kind of immune response you mounted, and we don't have the tools to measure your antibody levels right now. We're working on them, but we don't have that, that quantitative analysis. So to answer your question directly, if anyone has had COVID, whether it was a mild case or even in the intensive care unit case, we still say after 90 days to get the vaccine.
You would never give it to a person that's actually sick with the COVID at that time, though, would you?
Absolutely not. No, definitely would not. Nope, it's got to be 90 days after you're done.
We have a nephew who is educated. He's a veterinarian. He says he and his wife are not going to get the vaccination. What in the world would be, why would a person even that's in medical science, why would they think that? What would be a good argument to give them?
Does he give you a reason?
Well, no, I don't know. I think it's maybe because he doesn't like government telling him what he should do. Maybe that's it. I don't know.
So, well, Donna, I mean, I guess the important thing is to ask him. And the reason why I say that is because, right, people don't like to be told what to do. And I can appreciate that. However, if you look at Pfizer and Moderna, and I'm just talking practically, okay? I'm not Mr. Pfizer or Mrs. Pfizer. I don't work for Pfizer. I work for a clinical research company in which we get, I was offered the Moderna vaccine, but I was spread too thin. I was offered the Novavax. I was offered the Johnson & Johnson. So there was only so much of me to go around. So I could only take one trial. But to tell you the truth, I just signed a contract this morning with Moderna and Novavax. And so, because now this Pfizer vaccine has slowed down, we've already finished our enrollment. So I'm able now to take on different companies. My point is, it doesn't matter to me who's the winner, if it's Pfizer or Novavax. I could care less, because I don't work for them. But my point to you, Donna, is that for Pfizer, for example, that Operation Warp Speed, Pfizer didn't take any money from the government. Moderna did. It doesn't really matter. The bottom line is, if Pfizer did that just because they didn't want people to think that they were in cahoots with the government, that's why they did it, just to make a statement. But the reality is that the science is the science. And I understand that he doesn't, want to be told what to do. But if he ends up getting COVID, he's going to think very differently. And the only thing I could recommend is if he would talk to someone who had the illness, if he could go to hospitals and see the individual who's talking to you and I, Donna, 1 minute, and the next minute they're intubated. And it's like, how could that have possibly happened? It really messes with the physicians' heads. It really does, because you're talking to this patient who's perfectly fine, and the next minute they can't breathe. So unless you're you're seeing it, it's hard to believe because it's almost fantasy. But when you see it, you are scarred for life, you know? So I think that might help him. The science might help him. And then, you know what, Donna, there's people who are anti-vaxxers that no matter what you say, you just can't convince them. So you got to kind of let it go and do what's best for you.
Thank you.
You're welcome. Any other questions?
This has been very informative. Thank you so much.
Oh, you're welcome. Anytime. And Donna, I recommend, because you seem pretty savvy, for your own education, truly, go on the Pfizer page, go on the CDC page, take a look at that so that when he talks to you, you know, it's not just you reading what's in, you know, a newspaper that he may or may not agree with, or it may be political in his mind, or, you know, you're just going to say it just the way it is. And I guess a key thing, Donna, is it's not the United States government. It's a global, it's a pandemic. You know what I'm saying? It's globally. And when you look at our trial, for example, we're 6 countries. So, and this drug is being utilized all over the world. So it's not like, you know, the United States is in cahoots with Mexico and with Argentina and with, it's not like that. It's all over. And we're all, and the scientists, Donna, are from all over the world. So it's not like just the US, you know, FDA, or it has nothing. Honestly, I know politics plays a big role in a lot of our lives, but this is very different. And when you have all countries unanimously agree that this is a problem and that this is a solution to that problem, when do you ever see that? When do you ever see the world coming together? Almost never. Right? So it says something, doesn't it?
Yes, yes.
Now, I'm glad this is recorded. And Kaylin, when will it be available that we could have the recording?
It'll download right after we finish the meeting, so I'm able to share it out with anybody right afterwards.
Okay, because
Well,
like
is it
it
on YouTube?
really kicked in on the questions.
Yeah, and I can send it to our team, and I'm sure that they can put it on YouTube so that it can be shared out for sure.
That would be a good thing, I think, to share what she has said. Tell me your name again, Dr. Navarro.
Varano. It's
Varano.
it's a nice Italian name. V like in Victor, Arano.
Okay, thank you.
You're welcome.
Varano.
Yep, Varano.
Okay. So I've never tried to get the recordings off of YouTube. I will try to share this, see if I can tell them about it too.
Donna, I can always send it to your email as well.
All right, thank you, thank you.
You're welcome.
And then there was also some recordings I had done with Brandon Mark that was with Arrow, answering very specific questions, you know, one about pregnancy, and those were posted on YouTube also. So if you want to share it with the group, that might be beneficial.
Okay, and then you're going to have, so these are going to be every other week presentations by Dr. Varano. So the next one will be in 2 weeks. And do you know what that one's going to be about, Doctor?
I don't. I have to look at our list to tell you the truth.
Okay. But yeah, so every 2 weeks on a Friday, you know, right before happy hour, you can get excited and, you know, or start the happy hour early.
Great, absolutely. And if there's anyone who has, if you're going to be coming every 2 weeks, and if you have any questions, you could certainly, I could, how do they get it to me, Mark?
I mean, that's probably a good question. I don't know, Kaylin, would you mind if we shared your email address, Doctor?
See, you know what, it'll get
Yeah.
lost. So if I don't recognize who it is, I'll probably just think
Yeah.
it's spam.
Yeah, so
Well,
I
But we'll
mean,
figure something out.
they could probably send it to Kayla and she could store them, or they can send them to me and I can, keep like a database of questions.
Yeah, I was gonna say if one of us involved volunteers to kind of collect the questions, and then for the next session we can send them to you ahead of time, maybe I don't know, the week ahead, or a few days ahead leading up to.
Yeah, I think that's great, because if we're gonna have a series of, I believe, 10, how
I
many?
think it's total 10.
Yeah, it's a 10 sessions. So
Yep.
let's say, you leave today and you say, oh, I forgot to ask about the variants, or I forgot to ask about this, I forgot to ask about that. And you just, write the email. The next time we meet, I will answer those questions. And then you're constantly learning, or, I watched the video again and I really didn't understand what you meant by that, or this, or whatever it is. Just ask the question and we'll clarify it, because that's the goal. We want to make sure everything is nice and clear. So we're learning.
What I think is great is that, like, you are actually part of the testing and I mean, it's not like you're on the outside looking in, you were involved. So I think it's great to hear from somebody that actually was involved.
Yeah, it is. And like I said earlier, I strongly can say what Pfizer is putting on their website is really what I saw as a physician. It definitely matches up.
Are all of your presentations going to be about COVID? Or
No. Mark, can you pull it up, or do you want me to try to pull it up?
I'm not technically savvy. I'd probably lose all of you.
Okay. Yeah, no, they're not. Actually, quite honestly, this is going to be the only one about COVID. The other ones, and if you give me a second, I can look it up for you. The other ones are going to be, as I told you, I'm a geriatrician. So, and my passion is the older adult. So the other ones are going to be about geriatric syndromes. So, kind of what you see day to day. And let's see, hold on.
well, we would fit in that 81 and 83. I think you might call us geriatrics.
Well, quite honestly, it's kind of embarrassing to say, but you would be, so I started what's called the Elder Horizons program at Yale, which is a delirium prevention program. And my youngest patient was 80. So you would be one of my babies.
Oh, wow. It's been a long time since I've been a baby.
Yeah. So hold on, I'll pull it up because I know Larry and I had made a.
It's a good list. I can't remember.
Yeah, no, I don't remember. And let's see. I know Larry had. Well, I could definitely.
We'll send it out to.
We'll send it
I'll
out,
get it
yeah.
to Kayla, the
Okay.
whole list, and then Kayla can send it out to. We're making a lot of work for Kayla for not showing up.
So yeah, we'll send it out. And then, the reality is, Donna, this is for you. So if you feel that there's another topic that's not on the list that you want me to address, I could certainly do that too. But for the most part, typically what I like to do is geriatric syndromes. And if my memory serves me correctly, I would like to do the first 2 sessions being what's normal aging. I think, Mark, that's what we were talking about, is normal aging. And what I typically do is I go from the head down to the toes, and I talk about all the different organ systems and how is it normal aging, is it pathological aging? And I start with the brain, the head, the eyes, the nose, taste, all the organ systems, heart, lung, GI, kidneys, musculoskeletal, neuro, the whole bit. And it takes 2 sessions. So that's what I usually start off with, is a normal aging 2 session. And then I go into more details of differentiating depression, dementia, sleep, incontinence, all those types of syndromes that we encounter day to day.
Could somebody get on here and listen to you that's not a resident in an Aero community?
Mark, do you have that answer?
I think we could probably, probably share the, I'm not really sure. That's a Caleb question. That's, if we
But if
could
they
share it
have
outside
the,
of Aero.
The login number, it looks like they could do that.
Yeah, I know the Zoom goes out to specific individuals, and
Okay.
I'm not, do you know Kaylin?
Kaylin
I'm
said-
sorry, I missed that
Kaylin,
question.
yeah.
I'm hopping back and forth between Zoom calls, so I missed that question. I'm sorry.
If somebody outside of the Aero communities would like to listen to, so Donna would like to invite somebody, like a friend of hers, to be part of the Zoom. Is that possible?
Call you right back.
Yeah, actually, so any of our virtual events, we share those out on our Facebooks for our communities. So like family members, if they want to join, they're welcome to join, hop on this link at the scheduled time. If she has a friend who lives in another community who wants to listen in, all they have to do is join this link at the scheduled time, and they could listen in as well.
Okay, thank you.
So spread the word. Spread the word, and maybe I learned a lot today. So I mean, it was really good.
We did too.
Great.
Yes.
We did too. Very
So I think we need an hour and a half.
Well, with our schedule, I mean, most of the programs, I think when you guys are scheduled, Dr. Varano, I think you're going to be the last virtual of the day. So you really have, all the time that you need. So.
Okay, sounds good.
Yeah.
All right, well, thank you everyone for coming.
Thank you so much.
And I'll be in touch with you.
Okay, sounds good.
All right, see you later.
See you next time.
Yep.
Bye-bye.
Bye-bye.
Bye.